As India embarks on a massive COVID vaccination campaign, I think it's a good time to revisit our knowledge about anaphylaxis. In this two-part series, in the first video, we look at the intricate matters of the diagnosis of anaphylaxis. I'm only going to depth of what are practically important, not much into the theoretical aspects of it. In any medical emergency, first you have to suspect the diagnosis. Now, in anaphylaxis, most of the time it is very straightforward, but not always. I will ask you a few situations, and I would like to take note. Please find out what you think about whether it is an anaphylaxis or not. Now, one patient is given COVID vaccine. He suddenly develops breathing difficulty and hypotonic. There is no rash or itching. Will you consider anaphylaxis in such a situation? You are about to give the second dose of COVID vaccine, I mean. The patient says last time when he went home nearly after 3 hours, he vomited several times and became tired. He was brought to ER and by the time he was well and active. Here there are many points. He went home after 3 hours. 3 hours later only the symptom developed. He never had any breathing difficulty or anything. And he only had vomiting several times. He became tired. It was so severe that the relatives thought that he should come to the emergency. But he was well and active. That means he recovered by himself. Well, a diagnosis of whether the first one was anaphylaxis is important. If you are considering anaphylaxis in the first Covaxin administration, then the second dose you will have to postpone or give it under very controlled situation. Therefore, what do you think in this particular situation? Now we have another situation where 1 hour after vaccination, the patient suddenly collapses, comes to ER and is having thready pulse and breathing difficulty. Again, there is no rash. Now remember, normally we ask people to remain in the ER after COVID vaccination for only 30 minutes. That is what is normally advised. But here he comes back after 1 hour and definitely has features of a shock. Therefore, will anaphylactic shock be your first diagnosis in such a situation? Now there's another problem here. He's a known asthmatic food allergy. He comes with breathing difficulty after, say, 4 hours after vaccination. Now you might consider why in the hell was he given this vaccination if he is asthmatic? Now the patient did not reveal it to the vaccinator purposefully because he wanted the vaccination and he was okay. You start treating him with salbutamol and steroids because he came only after 4 hours. He shows only marginal improvement, his oxygen requirement goes up. Will you suspect anaphylaxis? And what are the specific features by which you can make a differentiation, if at all, between anaphylaxis and acute asthma in such a situation? I will come back to the answer to these questions after we finish discussing the diagnosis of anaphylaxis. Now let's look into the definition. Mind you, this definition is very important to know which organization, from where you are learning the definition. I picked it up because this is the World Allergy Organization Anaphylaxis Guidance 2020, the latest I have taken. Why am I talking about this? Because definitions are very, very variable between one to other. Now, how does it define? It defines anaphylaxis as a serious systemic hypersensitivity reaction that is very rapid in onset and may cause death. Note that it defines it as serious systemic hypersensitivity reaction. Severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, or circulation, and may occur without typical skin reaction or circulative shock being present. Therefore, it can occur without typical skin features, that is rashes, edema, etc., itching, etc., or even shock. Note two things here. It defines it as a serious systemic hypersensitivity reaction. I'll come to that later. and it says may cause death. It doesn't cause, that means it need not cause death all the time. Why am I emphasizing it? This is the definition of the world allergy also in 2020. And it also states that it is potentially life-threatening. It doesn't say that it is always life-threatening. The same organization in 2011 stated it as a serious life-threatening emergency. Therefore, in 2011, they used the term serious life-threatening, which they have deleted in 2020. Now, that is even now reflected in most of the other international guidelines, and they are asked to change it. This is the European guideline, allergy and asthma clinical immunology guideline. Again, defined it as a severe life-threatening event. Now, if you look at the American also, American allergy asthma immunology guideline, it again says life-threatening. And the WHO also defines it as a life-threatening systemic hypersensitivity reaction. Only the Australia Asia immunology, I think this one, does, and the NIAID. NIAID is of course the National Immunology Asthma Guideline of America, does not define it as, it defines it as serious allergic reaction. Therefore, note that there has been a difference now. The word serious life-threatening is now taken out of the definition in the latest definition by the World Allergy Organization, but still it hangs on in many other international guidelines. Why is it so? Because this is very well illustrated in the article by Archives in 2018, because they talk about myths, facts, and controversies in the diagnosis of anaphylaxis. Actually, it is reflected in most of the other articles also. Anaphylaxis can be life-threatening, but in reality, majority of reactions do not result in severe outcome. This is not known even to many doctors. Many reactions are not treated appropriately, yet fatal anaphylaxis is fortunately a very rare event, with a case fatality rate of 0.001%. Therefore, many times you don't diagnose it, many times you don't give the appropriate treatment, that is adrenaline, but the patient survives. Or in other words, the patient survives in spite of our treatment. But this can also be a problem when it really happens. You are taken aback, you are taken by surprise, because this is potentially life-threatening illness. But the main problem here is severe anaphylaxis, however, is unpredictable, and severe reactions may mimic mild anaphylaxis in the first instance. Therefore, in the beginning, the anaphylaxis may look like a small rash or small itching, or patient may say, look, I am not able to swallow, etc. And later on, it will turn out to be a severe anaphylaxis. Therefore, this is the big problem in it. It very rarely causes death, but sometimes where what starts off as a very mild reaction progresses very rapidly to death. Especially for the sake of the students who appear for in a British exam, whether they belong to the emergency medicine, pediatrics, or general medicine, should note that NICE guidelines, even now, NICE guidelines 2020, the latest one, also holds on to the definition that anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitivity reaction. Therefore, if you are a person who would appear for exam, the NICE guidelines, even now, the definition is it is a life-threatening, generalized or severe systemic reaction. If you make a mistake in the definition, it may not reflect well in your performance. Now, how does it explain it? Now it says that it makes a distinction and says that in the emergency department, a person who presents with signs and symptoms given above may be classified as severe allergic reaction rather than an anaphylactic reaction. It uses a word called severe allergic reaction and says that you have to treat it with and throughout this guideline, anyone who presents with such signs and symptoms is classed as experiencing a suspected anaphylactic reaction. Therefore, it uses the term severe allergic reaction or severe or suspected anaphylactic reaction and says that even people who have mild or moderate allergic reaction are at a risk and may subsequently present with suspected anaphylaxis, and all of them will have to be treated aggressively. Therefore, it holds on to the term that anaphylactic reaction is a life-threatening one. At the initial stages, you call it severe allergic reaction, and when it becomes anaphylactic, when it becomes life-threatening, use the term anaphylactic reaction. Therefore, in retrospective, therefore, this playing with words. But I think it is important that students who appear for an examination in UK should know this differentiation, because this is even now in 2020 guideline of the NICE guideline. I want to emphasize one more thing in the passing. We often believe that there are no hives, so it can't be anaphylaxis. Many times when there is no urticaria, that's what we look for in a case of allergic reaction, especially anaphylaxis. One thing we have to note, which has been very much emphasized in this particular article in the archives, is that cutaneous symptoms, most commonly urticaria or hives, are absent in about 10% of the anaphylaxis reaction. Some other articles say up to 20%. And when present, may be delayed in onset. That also you should realize. Sometimes it may not be present immediately. It may come after 10 minutes when it's too late to give the alternative. Therefore, remember that this is very important when you see a patient. Therefore, before we leave the definition, let's revisit the most important, probably the most important definition, which I think, which is the WHO definition in 2020. It says anaphylaxis is a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. Severe anaphylaxis is characterized by potentially life-threatening compromise in airway, breathing, and or the circulation, and may occur without typical skin features or circulatory shock being present. At least one definition all the students should know very carefully. I think this one is the one. Note, it is a serious systemic hypersensitivity reaction and not a life-threatening as its most other definitions say, and may cause death but need not cause death, is not fatal most of the time, and it is potentially life-threatening and not life-threatening as the earlier definitions have been stating. After having spent some time dwelling on the definition, let's now look at the now let's discuss something about the most important point about the diagnostic criteria. Now, this is given in the position paper of WHO in 2020. Therefore, this is the latest one. Previously, there were 3 criteria. Now they talk of 2 criteria only. They have made 3 into 2. And that's all we will discuss. But students of emergency medicine and postgraduate students would better know the previous one also, because that is the one which is given in most international guidelines. Now, when you look into this, you look, anaphylaxis is highly likely when any one of the 2 criteria are fulfilled. In criteria number 1, you need have a skin involvement, and along with that 3 other parameters. That is criteria number 1. In criteria number 2, you may or may not have, you need not have a skin involvement. Even without skin involvement, you can diagnose if the other criteria are fulfilled, you can diagnose the anaphylaxis. Now, let's read through it. Is an acute illness, acute onset of illness, criteria number 1, acute onset of illness, minutes to several hours with simultaneous involvement of the skin, mucosal tissue or both, generalized hives, pruritus or flushing, swollen lips, tongue, uvula. These are the skin symptoms or signs. Remember, along with that, we need have any one of the other 3 criteria. What is to note here is acute onset of illness, minutes to several hours. It doesn't say how many hours. That's a problem actually. It is 4 hours, 6 hours, it doesn't say. We will be discussing it in the subsequent slides also. And respiratory compromise, any one of the following. 1 is respiratory compromise, 2nd is cardiovascular, and the 3rd is gastrointestinal. Respiratory compromise, which might be dyspnea, wheeze, bronchospasm, stridor, reduced peak expiratory flow rate, or hypoxemia. If you give a Covaxin and you find that the SpO2 has dropped, that is enough to diagnose anaphylaxis. If he has skin rashes also, remember that. Now, the other one everybody knows is reduced BP or associated symptoms of end organ dysfunction like hypotonia, collapse, syncope, incontinence, etc. The third one is a little more controversial. That is severe gastrointestinal symptoms. Severe crampy abdominal pain, repetitive vomiting, especially after exposure to non-food allergens. Therefore, if you have a rash and severe gastrointestinal symptoms, that is enough to diagnose according to this criteria as anaphylaxis, even if there is no respiratory compromise or fall in BP or any cardiovascular symptoms. And there is another thing, in the previous definitions, in most of the international definitions, even now, the severe gastrointestinal symptoms are written as persistent gastrointestinal symptoms. Why have they made the change? Because there was something controversial, how long you should persist before you make a diagnosis. And sometimes, people waited too long and it was too late for the patient. Therefore, now they say it is severe gastrointestinal symptoms. What do you mean by severity is left to the judgment of the doctor or the nurse who's with the patient. Repetitive vomiting and abdominal pain along with an allergic skin rash is enough to diagnose anaphylaxis. Now we come to the second criteria, which is more relevant to us because here it says an acute onset of hypertension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, minutes to several hours, even in the absence of typical skin involvement. But what you have to notice, if there is an exposure to a known antigen or probable antigen, that is what happens when you give any immunization, including COVID-19 vaccination. Therefore, if the patient develops hypertension or bronchospasm or laryngeal involvement, even if there is no skin rash, you must straight away diagnose it as anaphylaxis. How do you know whether there's laryngeal involvement? All of us know what a stridor is. But vocal changes and odynophagia are also features of laryngeal involvement. Therefore, if a patient after immunization suddenly tells you, doctor, I am finding it difficult to talk or my voice has changed, or he says, I'm not able to eat anything, I'm not able to drink, don't laugh it off, it might be a sign, or probably it is a sign when you are given COVID vaccine, of anaphylaxis. This fact, odynophagia and vocal changes, is something new to me. I was not very much aware of it. And the significance of severe gastrointestinal symptoms had not struck me unless till I read this literature of anaphylaxis in detail. There are subtle and significant differences between the various international guidelines, but I will stick to only one definition, which we have already discussed and not confused. But I would like to take one line from the WHO position paper in 2011, which states that the key to diagnose involves pattern recognition. Sudden onset of characteristic symptoms and signs within minutes to hours after exposure to no potential agent, often followed by rapid progression. This is a very important word. If the symptoms rapidly progress in front of you, there is one other thing which you should immediately think of, that you are probably developing an anaphylaxis. A child becomes dyspneic and rapidly deteriorates, you must immediately think, okay, probably it is an anaphylaxis. Just develops a hypotension and rapidly progresses. Again, the rapid progression is a very key point in this definition. Sometimes even health personnel are surprised that the same vaccine which was given previously did not produce an anaphylaxis, but the subsequent ones did produce. This is because anaphylaxis mechanisms can have triggers also. One of them is, of course, emotional stress. If the patient is stressed emotionally because of the environment or some other reason, that can trigger an anaphylaxis in a patient who has taken the same medicine or the same injection previously. And the other is exercise. If he comes running to take the immunization, climbing upstairs, he might be another point. Now, many times in many places, immunization are given in the airport. Now, that's a dangerous thing because one of the disruption of the routine, your sleeping pattern, is another reason that may trigger an anaphylaxis. There's something which I want to tell you because people might say, okay, he has taken the vaccine last month and this time he develops a few rash. Is not going to be anaphylaxis, is not right. He can still develop because of the trigger factors. One or two points to note is that the position paper of WHO in 2020 emphasizes that some definitions imply the need of multiple organ involvement. And they say that this is not a good definition because it need not involve multiple organs because severe symptoms and death can present in only one organ is involved. Sometimes after an injection, the only thing that you will find is a hypotension and the patient might die. And that's another thing. And such a definition is misleading and can lead to inappropriate treatment. Now you must be able to differentiate from a syncope. If you are diagnosing an anaphylactic shock in a patient who has syncope, just syncope, you look like a fool. But the difference is not that easy. Both of them have a life-threatening event, which is hypotension. Therefore, syncope is one condition, which is we know what it is, it's very often seen. But hypotension can occur in both syncope and anaphylaxis. Therefore, if you have given the injection and he develops hypotension, that is, according to the second criteria, enough to diagnose anaphylaxis. Then how do you say it is not anaphylaxis and syncope? Now, syncope is relieved by recompensing and is usually associated with pallor and sweating. The first thing you do in a patient who has suddenly develops hypotension is to put him supine. And it should relieve the hypotension immediately, within minutes in syncope. And often at the beginning of syncope, you will find the patient is having pallor and starts sweating. And there is absence of urticaria, flushing, and respiratory symptoms and gastrointestinal symptoms. But this is a tricky problem because that we have already defined that after an injection, after an allergen, hypotension alone is enough to diagnose it as anaphylaxis. Therefore, now there's no point in much telling that absence of urticaria, flushing, respiratory symptoms, gastrointestinal symptoms. If any one of these are present, we would definitely diagnose it as anaphylaxis. If it is not present, how are we to say that it is syncope or anaphylaxis? Now they say if there's typical pallor and sweating, then it is syncope because the patient becomes pale and suddenly he falls down. There will be no health personnel who has not seen a syncope. But remember one thing. Probably one thing you can relieve is you put the patient on the supine position and may raise the legs a little. If he recovers immediately and he was pale and sweating, then it is syncope. You need not proceed further. But if he doesn't recover immediately, you may have to diagnose it as an anaphylaxis and act accordingly also. The other thing which we have to think about is acute severe episode, asthma, which I referred to in the initial slides. Now in asthma, in both this, there can be wheezing, coughing, shortness of breath can occur in both asthma and anaphylaxis. Now how do you differentiate? Of course, if there is itching, urticaria, angioedema, you will immediately diagnose it as anaphylaxis because in asthma you don't expect itching, urticaria, and angioedema. But there are two other symptoms by which you can think of anaphylaxis, and that is abdominal pain and hypotension. Therefore, if you have an acute asthma and you have hypotension, which normally occurs in acute asthma in only very terminal stages, or severe abdominal pain, sometimes abdominal pain does occur in asthma, but abdominal pain and hypotension are signs of anaphylaxis more than acute asthma. Therefore, this is one way how you differentiate between these two. Both these can be tricky and it requires a lot of presence of mind and knowledge and experience to say, look, this is not anaphylaxis. And acute anxiety and panic attack. More common than acute anxiety and panic attack is hyperventilation. Patient is emotionally stressed, he will start hyperventilating. But this is a very common psychiatric emergency where the patient feels a sense of impending doom, breathlessness, flushing, tachycardia, gastrointestinal symptoms can occur in both anxiety, panic attack, and in anaphylaxis. Therefore, this is a real issue. So the patient is coming to a COVID immunization center, is anxious, he finds everybody sitting there very serious. His blood pressure, SpO2 is measured, he becomes anxious, and he can go into immediately after injection, he can go into hyperventilation. Now, if there is urticaria, angioedema, wheezing, and hypotension, urticaria and angioedema, then is both or wheezing and hypotension. They are unlikely to be in anxiety or panic attack. Now, increasingly, the more and more doctors are there who are not. You must be able to pick up a wheezing in a hyperventilating patient, whether there is wheezing or not. That is why even in present day practice, physical findings are important, because if you pick up wheezing, it becomes an anaphylaxis. If the lungs are silent, even in a hyperventilating patient, you can immediately think that it is probably an anxiety or a panic attack. Remember that in an acute situation when you are deciding on anaphylaxis, when the life of the patient depends on your clinical judgment, delay in minutes can cost his life. Your knowledge as well as your presence of mind is very important. That is why I picked up this topic for presentation. And even very competent person can make mistakes. Now, the clinical diagnosis of anaphylaxis is the diagnosis of anaphylaxis is a clinical one. But and there's no lab investigation, which is very important. But if you look at international guidelines, they would talk of measuring mast cell tryptase, collecting blood, which is done. A serum sample is usually collected 15 to 180 minutes of symptom onset, and a further convalescent serum 6 hours later. Now, this is for retrospective diagnosis of anaphylaxis and analyzing it probably for medical legal reasons also. It is non-specific. It's not important probably in our practice, but if you're appearing for an exam, it's worth knowing it, because it's one of the things which you should not miss out when you manage an anaphylaxis in a Western country. Now, some comments I would like to pass. No set of diagnostic criteria for anaphylaxis will provide 100% sensitivity and specificity. That's something which we want in a very critical situation like this. Therefore, the criteria developed by this panel is only shown to be an aid in the diagnosis of anaphylaxis. The accuracy of these criteria were retrospectively evaluated in ED settings and found to have 97% sensitive. Therefore, you miss only 3%, but you still miss 3%, and 82% specific in one study in the ED. That means 18% in which you thought it was anaphylaxis, it was not. But there are other studies which show that the negative predictive value was 98%. That means if I say it is not anaphylaxis, it is not anaphylaxis, 98. Positive predictive value was only 69%. What it shows is I am telling it is anaphylaxis. In nearly 31%, it was not anaphylaxis. Therefore, showing that a significant number of patients who meet the criteria might not have anaphylaxis. Therefore, even with all this diagnosis and criteria, you will underdiagnose or overdiagnose anaphylaxis. You can't be 100% sure. But what do these? The central point, as far as we are concerned, for the definition as well as the diagnostic criteria, is to discern when an injection of epinephrine is indicated in the management of a patient. That's what we want to find out. Unfortunately, there is no definition or diagnostic criteria which is 100% specific and 100% sensitive, even in a real emergency like this. Therefore, there are two groups. One group of participants who are concerned that we don't have a simple clinical definition which could not include all subjects with anaphylaxis. Their concern is real. I say it is anaphylaxis, but there's 1% chance it may not. If I am not diagnosing all anaphylaxis and I miss out on anaphylaxis, some patients can die. The other group is more concerned. You make it more specific, more sensitive. you will be giving adrenaline and causing false alarm of a diagnosis of anaphylaxis unnecessarily. Therefore, this issue pertains. And to add confusion to the problem, there are patients who can present very early, who may not meet any criteria, may not meet the criteria for diagnosis of anaphylaxis, but will still require injection adrenaline. Like you give, somebody takes a peanut and he was previously allergic to peanut, he starts developing rash, that may be an indication to give him adrenaline. Therefore, we all, in spite of all these definitions and all this criteria, individual judgment becomes important. Therefore, what do the people who write the guidelines do? They put the responsibility straight back onto the poor treating clinical treating nurse or the doctor. They say, therefore, these criteria are useful but do not replace clinical judgment. Straight away, they are putting after all this discussion, they are putting the responsibility back on you. It is important for healthcare providers to recognize the variable presentation and progression of anaphylaxis. Recognizing milder anaphylaxis is important, not only in preventing progression of a specific event to a more serious outcome, but in preventing recurrent episodes in the future. In spite of the fact that only 0.1% of the anaphylaxis progress on to fatality, these statements will cause palpitation in most of the health workers. I hope it doesn't cause an anaphylaxis. But it is important to remember that the diagnosis and treatment of anaphylaxis are not cakewalks. Now let's go back to find the answers to the questions I asked at the beginning. Now, child is given COVID vaccine. He suddenly develops breathing difficulty and hypotonic, no rash or itching. Now, this fulfills the criteria of second criteria for diagnosis of anaphylaxis. That is, after an allergen, if he develops breathing difficulty or becomes hypotonic, then that's enough. The rash need not be present. Therefore, it is again, you have to diagnose anaphylaxis in this situation. You are about to give the second dose of COVID vaccine. The patient says last time when he went home nearly after 3 hours, vomited several times and became tired. He was brought to ER and by this time he was well and active. Here there are 3 things. It happened after 3 hours, but we know that several hours, that's what the definition says, doesn't say how many hours. 3 hours can come under that definition. He vomited several times, that is a persistent gastrointestinal symptoms, and he was tired, probably his blood pressure was low. He was brought to ER and by the time he was well and active. Spontaneous recovery is very well known. Therefore, again, this has to be taken that this patient had an anaphylaxis when you gave the first dose. This is very important because when you give the second dose, you probably will have to postpone it or you will have to take extra precautions by calling your seniors and being well prepared for an anaphylactic shock when you give the second time. Now, after vaccination, 1 hour suddenly he collapses. Come to ER and he's having a thready pulse and breathing difficulty. There is no rash. There are only 2 points here. He comes only after 1 hour. He develops, can he collapse after 1 hour? Yes, it is a few hours, few minutes to hours, and they don't say again how many hours. Rash need not be present in 10 to 20% cases. Therefore, even in this patient, you will have to suspect it as anaphylaxis and treat him accordingly. Now, he's a known asthmatic with food allergy, comes with severe breathing difficulty 4 hours after vaccination, does not improve with salbutamol and steroids. Definitely, you will have to suspect anaphylaxis also. And we have already said that if he has hypotension and severe abdominal pain in an asthma, you have to think of anaphylaxis. And 4 hours comes under the purview. 4 to 6 hours is, though they say few hours, it usually denotes 4 to 6 hours. Therefore, what do you mean in all these conditions? You have to suspect anaphylaxis. I want to drive home this point. That's why I asked this question and gave you this answer at the end of this chapter of the presentation. With this, we come to the end of the first video of this 2-part series about diagnosis and management of anaphylaxis with special reference to COVID vaccination. The second part, discussing the management, I'll put it up in a few days, in a couple of days' time. I'm Dr. A. Padmanabhan, and I have put up much of pediatric videos in this particular site, YouTube site. And you can also see my blogs on pediatric topics on wordprocess.com, the web address of which I have given here. Thank you till we meet with the second video series.